Hi, Laura. Thank you so much for making time for this conversation today.
Of course, I'm really happy to be here.
Before we get into it, could you just share a little bit about yourself?
Yeah, of course. So my name is Laura Laursen. I am a OB-GYN in Chicago, practicing full spectrum OB and GYN care. I'm a fellow of the American College of OB-GYN, and I focus a lot on inpatient obstetrics and trying to improve birth outcomes for women or for all patients.
Excellent. And today we're going to be talking about vaginal and perineal tearing, specifically as it relates to delivery of a baby. So if we could just start, like, what is a perineum and what causes it to tear?
Yeah, so I feel like the perineum is kind of this mysterious thing that no one really thinks about until they have a baby. And then you hear about these perineal tears. So if you think about your anatomy, there's the urogenital area and there's the anorectal area, right? So basically there's a vagina and there's the anus. And then there is a muscular layer between the vagina and the anus that supports your pelvic floor, and that's the perineum. So basically when a baby is delivered, as it goes through the birth canal and it crowns, the vagina expands, and the body is made to do that. And also the muscles of the perineum expand as well and stretch in order to allow passage of the baby's head. In that process, they can kind of expand a little too much, and it can lead to these tears.
Okay. And there are different degrees of tearing, aren't there? So if you could just kind of talk through those.
Of course. So the tears, the way that we talk about them are 1st degree through 4th degree. And that's the medical terminology that we use to kind of keep everything standardized. So a 1st degree tear is a tear that's just going to be in the vagina. It's not going to go through any muscles. It's going to just be what we call the vaginal mucosa. A 2nd degree tear is going to be that vaginal mucosa and also some muscles in the perineum. And then we get to the 3rd and 4th degree tears, which are the more complex tears, which are much more rare. And we'll get to that a little bit later. But a 3rd degree tear actually goes into the sphincter of the anus. So the anus is actually made of an internal anal sphincter and an external anal sphincter. The external anal sphincter is what you control. So that controls continence of stool and flatus. And then the internal anal sphincter is under involuntary control. So the body is controlling that completely on its own, and you don't have any control over that.
Mm-hmm.
And then the 4th degree tear, again, tears through the vaginal mucosa, the muscles of the perineum, the sphincter, and then it also goes into the rectal mucosa, so into the rectum itself.
Mm-hmm. Okay. And tearing during childbirth is actually quite common, right? Could you talk a little bit about that and the degrees of tear that are generally more commonly seen versus the 3rd and 4th? Yeah. So
70% of people who give birth are going to have a tear. And it's much, much more common in first-time birthing people than it is in people who've had multiple deliveries. And so there are some strategies that we can do to help, but it's going to be very, very, very common. The vast majority of these are 1st and 2nd degree tears. 3rd and 4th degree tears happen in only about 3% of birthing people. So very, very, very rare. But overall, there is a high rate of one of the lesser tears.
Okay. And do you, when I gave birth to my daughter, I had, the doctor said I had a 3.5 tear. Is that something do you hear that a lot as well? These you have the 4 degrees, but do you do 3.25?
Yeah. So it definitely can even get a little, the 3rd degrees we can actually subdivide into a 1A, a 1B, and a 1C. Mm-hmm. And that's where I was getting at kind of the internal versus the external anal sphincter. So a 1A is just going to do less than 50% of the external sphincter. Or sorry, a 3A, sorry. 3B is going to do more than 50% of the external sphincter. And then a 3C is going to do the external and the internal anal sphincter.
Okay.
Yeah. So 3.5, I would assume they meant a
B or something.
B or something. Yeah, exactly.
Yeah. Okay. And what are some of the risk factors that can increase somebody's chances of having a laceration?
Yeah. So the biggest risk factors are how big the baby is. So if the baby is over 9 pounds, you're more likely to have a laceration or a larger laceration. Use of an instrumental delivery, so using forceps and vacuum, make it more likely to do that, which is one of the many reasons why if we can avoid it, we try not to use forceps or vacuum. Obviously, there are indications when it's necessary, but that's one of the reasons why. Long second stage of labor, so long pushing time. First stage of labor is from start of labor to getting to 10 centimeters, and then second stage is from 10 centimeters to having the baby. So the longer you push, the more likely you are to have a tear.
And what would you say is a long pushing time sort of for you in your practice?
So it varies a lot between first and second and people who've had multiple deliveries. So, the average amount of pushing for a first-time mom is going to be around 1 to 2 hours. And for a second-time mom or second-time parent, it's going to be closer to like 30 minutes. But anything up to 3 to 4 hours is actually within the range of normal. And as long as the baby is looking good, and the mom isn't too exhausted, is something that we can definitely work with. But if you do get up to those closer to those 3 or 4 hour pushing times, although it's still, like I said, within the realm of normal and definitely something that's recommended over a C-section, it does lead to a higher rate of these lacerations.
Mm-hmm.
Some of the other is that, so most babies come out with the head, with the face facing down, okay? And we call that occiput anterior. But occasionally the baby comes out like this, where the occiput is down, otherwise known colloquially as like a sunny side up baby, right? And so those make it harder to push the baby out. It's not, you could definitely have a vaginal delivery, but those parents definitely can push for longer. And in those instances, because of the way the baby's head is, it can lead to larger tears. And then some of the other things are, like I said, if it's your first delivery, you're more likely to. And then the last thing is something called shoulder dystocia, which in rare instances, the baby's head will deliver, but the shoulders will get stuck, right? Because it's head first, and then the shoulders have to go through the birth canal. So you like my little thing.
It's easy to shimmy out.
Yeah, exactly, my little shimmy. So as the shoulders go through, sometimes if those get stuck and we have to do maneuvers to get the shoulders out, that can lead to more lacerations as well.
And is that generally with a higher rate, a higher birth weight baby, that one might see shoulder dystocia a little more? Generally,
that's one of the risk factors for shoulder dystocia. Some of the other risk factors for shoulder dystocia are diabetes, a patient who has diabetes, and some of it is really unexplained, and we've had it in smaller babies as well. But yes, those are the main risk factors.
And why is it with a patient with diabetes? Is that again just because they might have a larger baby, or because the proportions are slightly different?
It's actually proportions. So the patients with diabetes are more likely to have larger babies. So that's one factor. But even if the baby is not as large as another baby, without diabetes, their proportions are different. So their shoulders are, they collect more of their weight in their shoulders than they do in other parts of their bodies. They're kind of built like linebackers, is what we often say. Yeah.
Okay.
Yeah. Yeah.
Is there anything that a person can do to help prevent perineal tears,
Yeah,
either during pregnancy or labor?
Yeah, there's definitely a few things that can be done. So I think before you, in the third trimester, before labor, one of the things that you can start with is doing perineal massage. And you can either do this or you can have your partner help you with this. But basically, you just place 2 thumbs into the bottom of the vaginal canal and basically press downwards towards the anus into the sides of the vaginal walls. So you're going to kind of press that way in that direction and hold it there for a minute. And then you're going to feel a stretching sensation, which may be, a little unpainful, but if you breathe into it, you'll feel those muscles stretch. And then you can continue by actually massaging that area kind of in a U shape for about 2 to 3 minutes. And if you repeat this, I don't know, about 2 to 3 times a day in your third trimester, there have been some studies that have shown that can decrease the rate of higher order lacerations.
Okay. And what about during labor? Like, does position that you're laboring in make a difference, or anything?
Yeah, there's a few things you can do. One is using a warm compress. So asking your either your midwife or your OB to place a warm compress on the perineum as you're pushing, or you don't have to do it the whole time you're pushing, but as you're crowning, can help a lot. Having the healthcare provider support your perineum as you deliver can really, really help. So you'll during delivery, you'll oftentimes see the delivery provider really holding pressure on the perineum as the head and the shoulders deliver, and that we're trying to kind of hold the muscles together and support them.
Would you recommend if somebody, if somebody felt that wasn't happening, would you recommend, speaking up in that moment, asking the healthcare provider to kind of, do that?
Provide some support there? Yes, I definitely would, because that's probably the biggest thing that has been shown to make a difference out of all of these things that we're discussing.
Okay.
And then the other thing that is helpful, but depending on whether you have a medicated or unmedicated birth, may be more difficult, is having controlled pushing towards the end. So really, instead of, you're pushing really hard, I know, you've been pushing for a long period of time, you're ready to meet your baby. But at the end, during that expulsion phase, really listening to the provider's voice, really dialing it in and doing small, short pushes instead of a large expulsive effort can help stretch the perineum and lead to less tearing as well.
Okay. Yeah, that's really good to know. What is an episiotomy and how's that different to a tear?
Yeah. So episiotomies, luckily, are becoming more and more of a historical thing than they are becoming a standard part of practice. I probably have done 1 or 2 episiotomies in my entire career, and that's generally standard of care for most providers at this point. So an episiotomy is actually a controlled cutting of the perineum, and so you can either cut straight down in the middle, down towards the anus, not going all the way to the anus, or you can go kind of off to the side to try to avoid the anus. The thought process behind the episiotomy was twofold. One is it would give the baby more room to deliver. And 2, by doing a controlled cut, you would decrease the risk of having larger order tears or tears in multiple places that weren't as controlled. The data has really borne out that those things are not true. And episiotomies actually lead to higher order tears, some more 3rd and 4th degree lacerations, and don't assist with delivery at all. That's not to say that there is absolutely no indication for episiotomy, right? I have had instances, like I said, where I'm with a shoulder dystocia where I need more room to get the shoulders out and it's an emergency, or the patient is really, really close to delivery and it's just not right there. And I have an informed consent discussion because the baby's heart tones aren't looking reassuring. So things like that, it is possible, but as a standard practice, it's definitely not recommended anymore.
Okay. What is the general process for treating more minor and common tears versus, the 3rd and 4th degree lacerations that are more complex to repair? Like, when you're in that situation, you're delivering a baby, like what's your sort of standard process?
So first step, so baby's delivered, then we go ahead and we deliver the placenta, right? So and then once we make sure that the bleeding's okay, the placenta is delivered, then we inspect the perineum and the entire vagina to check for lacerations. The biggest thing with that is if there is a laceration, I'm going to first check with the patient to make sure they have adequate pain control. If they have an epidural, the epidural will still be working, and that's definitely an option. If the patient does not have an epidural, I will give them lidocaine in the area that I'm repairing to numb it, and I'll make sure that the lidocaine's working before I go ahead and repair the laceration. Other options for patients who had an unmedicated birth is that you can give them some IV narcotics at that point in time, especially for the higher order lacerations, if the lidocaine just isn't cutting it and someone needs, something a little bit more. So that's definitely something you can ask for as well.
Okay.
And then once so let's say I've decided it's a 1st or 2nd degree lacerations, you just use actually one running stitch. So oftentimes a question I will get, well, how many stitches are you putting in me? It's not like I'm doing individual stitches and then tying each one. I get one long piece of suture and I'm kind of running it down to repair the laceration and then tying it. So generally that can be done, or with the 1st and 2nd degree, it can be done for sure in the labor and delivery room. Takes about 5, maybe 10 minutes. It should be generally very quick. And we're just using, like I said, some suture to bring everything back together.
And that will dissolve.
And it will dissolve on its own. Yeah, the suture will dissolve. We like to say that the vagina itself is pretty forgiving. We'll talk about the 3rd and 4th degrees a little later, but with the 1st and 2nd degrees, there's so much blood flow, especially after childbirth, to the vagina and the perineum, that those, once we close them up, they heal very well.
Okay.
Yeah.
And what would you recommend for somebody, in those early days of postpartum, if they have a tear or an episiotomy, what would you sort of recommend? So
the biggest things are going to be warm combination of either cold packs. So some of the Nyssa underwear is really wonderful because you can actually put the cold pack there, and that helps a lot with that. Using witch hazel really helps with the burning. And then using, there's like Dermaplast or the equivalent of, which is a numbing spray to numb that area, really helps as well. Some of the most pain people feel is actually while they're urinating. So while you're urinating, it often helps to use a squeeze bottle with water in it to dilute the urine. So therefore you're not having that stinging. Exactly. Yeah. So that's probably the biggest thing. And then just giving it some time to heal.
Yeah. And what about, does the management differ depending on the degrees of tear? For example, as I mentioned, I had a pretty severe 3rd degree tear, and I had to, I couldn't sit down in a regular seat, right? So I have one of those inflatable donuts to sit on. Like, how would it differ if you had a more severe kind of tear?
Yeah. So unfortunately, the 3rd and 4th degrees, the recovery process is more challenging, and it's really unfortunate because now you're home with the baby and you're going through all the postpartum stuff, and now you have this. So, getting back to the repair, some of the repair is the same, right? Where I use that running suture to repair, because if you think about it, there's a 2nd degree plus the areas of the anus that we have to repair. The difference is with the 3rd and 4th degree is I actually tease out the anal sphincter. So I am grabbing with my instruments, the anal sphincter, and making sure that I see all of it before I repair anything. And then once I see the entire external and internal anal sphincter, I actually repair the external and internal separately to truly, and you're putting like 4 individual stitches in each of those to make sure that you're truly coming back together and it's really, really reinforced. So that process does take a little bit longer. Again, like vast majority of the time, it can be done in the labor room. In very rare instances, would you have to go to the operating room because of visualization, or if the patient's pain control wasn't able to be managed. But that's actually never happened to me, but it can happen. Yeah. And then afterwards, the pain is more difficult. I was going to say the donut does help a lot. Sitz baths are really helpful. So just a shallow bath that you can sit in really calms that area for sure. And then stool softeners are of utmost importance. So we don't want any straining, as you can imagine, if there's been any issues with the anus. So we give patients multiple stool softeners, and we want the stool to kind of be, I don't mean to be graphic, but to be just like frozen yogurt, like a soft serve kind of consistency, so that it comes out without any straining. And we want that for about, 4 to 6 weeks while things are really healing. We don't want people to put strain on that for quite a while. And so stool softeners are going to be really important. Pain control, like generally Tylenol and ibuprofen are fine, but again, with these 3rd and 4th degrees, they can be extremely painful. So sometimes a short course of narcotic pain medications are needed. And if you feel like your pain is not being controlled with the standard ibuprofen and Tylenol that your provider is giving you, please let them know. And they should give you a short course of narcotics, which in short courses are not, we're not worried about addiction potential or anything like that. We want to make sure that your pain is controlled.
Yeah. Okay. And what would you recommend for follow-up care, like with a, medical provider, sort of, I suppose, regardless of what degree of tear you've experienced, but, should you be trying to, have a follow-up with your OB-GYN or have pelvic floor therapy, things like that? How can that help?
Yeah. So with all the tears, you're going to want to see your OB-GYN by 6 weeks. With a 3rd and 4th degree, you often want to see your OB-GYN even earlier than that, closer to like 3 to 4 weeks, just to make sure things are healing okay. We in our practice actually send everyone with a 3rd and 4th degree laceration to our urogynecologist. So urogynecologists are doctors that specialize in the combination of gynecology and urology, and then a little bit of colorectal as well, right? And so we actually have all of our patients follow up with them so that they can inspect the tear and make sure that it's healing well, because they're really the experts in this. And they can actually tell you too, is that if you are having any side effects like leakage or incontinence, they can work with you and see if you need additional surgery or anything over time. And it's very rare that's needed, but it's important to have that contact with those doctors early on so that you're not worried about it if and when it happens.
Yes.
Pelvic floor physical therapy, I am a huge proponent of, and ideally every single patient who has a baby would go to pelvic floor physical therapy. No matter what your laceration is, no matter if you've had no laceration, your pelvic floor has gone through a workout and it needs some help. But definitely people with 3rd and 4th degree lacerations, and pelvic floor physical therapists can see you as early as 2 to 3 weeks afterwards to just start working on things. People talk a lot about Kegels and stuff like that. It's really hard to do a Kegel on your own without having a physical therapist, show you the right way to do that and to give you some feedback.
Yeah.
And then it's also a lot more than Kegels. It's a combination of strengthening those areas, but also relaxing too. So a lot of people don't realize this. So when we repair, even after delivery, the muscles are kind of traumatized. So they tensed up, right? And so they're not strong, but they're very tense. So the goal is to like calm it all down, relax the pelvic floor, and then build up that strength again.
Right. Okay. Yeah, that makes sense. And what are some of the long-term issues that somebody might experience if they've had a tear?
Yeah. So, there's long-term and short-term issues. So I think, some of the short-term issues are, like you said, pain is the biggest one. Pain with intercourse is something that people really don't talk about, but I think is something that's much more common and something that really we should be talking about a lot more. A lot of times people go to their OB at their 6-week visit and be like, okay, everything looks good, you can have sex now. And it's like, okay, well, first of all, I don't know if I want to have sex. And then even if you do want to have sex, it can really hurt. And the tear can make it, because I talked about the muscles being so much more tense, can make sex a lot more painful. That in combination of not having as much lubrication in the postpartum period, because you've lost so much estrogen, can make sex a really, really painful experience. So, I always tell my patients to go slow, only do what's comfortable, use lubrication. And if it's not getting better, come back to me or go to pelvic floor PT, because they, in just a few short sessions can work to make that a lot better.
Yeah.
But some of the long-term, and again, these are the rare effects, but some of the long-term things to look out for are incontinence of both stool, flatus or gas, and urine are all possible. Chronic pelvic pain, again, is possible. Or needing a repeat repair if you've had a 3rd or 4th degree, if it breaks down or if it doesn't heal very well. And then, off in that same vein about next pregnancy, right? So only about 5 to 6% of people who have a 3rd or 4th degree get another 3rd or 4th degree in their next pregnancy.
So can you talk a little bit more about that? Because I suppose, even just my own personal interest have been concerned about that, because it's like, okay, you've had a big tear.
Yeah.
It's time has passed, things have healed, but I suppose my instinct would be like, well, now that area is weakened. So yeah.
Right. So it's because you, because it's your second or because it's the 2nd or 3rd or whatever baby, the muscles have stretched enough and they haven't really gone back all the way. So there's already more room in the birth canal. That being said, I said only 5 to 6%, but like you could also put it as the opposite of, like 5 to 6% is a big number, right? You know what I mean? Yeah. And I think that really depends on the patient and what they've gone through and how terrible their recovery has been. So some of my patients are like, you know what? I never, ever want to go through that again. Please, let's do a C-section, right? And that is a totally acceptable thing. And I think especially if someone like had to get a repair or had to go to urogynecology, all these things, that might be something that is
risk it.
Totally reasonable, right? And American College OB-GYN says that we should offer anyone who's at a 3rd to 4th degree tear a C-section next time around. And that's totally something we offer.
Yeah.
Other patients are like, I'd really like to avoid a C-section at all costs, and I'll take that 5 or 6% risk and, do it again. I think for those patients, seeing physical therapy before, in pregnancy is going to be really helpful, because they can help with that perineal massage we were talking about and preparing you for childbirth for sure.
Yeah. That's a great point.
Yeah.
And as an OB-GYN, what do you wish more people sort of just knew about when it comes to vaginal tearing? Is there anything you'd like to see change in the medical community in terms of treatment, and also just in our sort of culture at large? Because I think this is something that I've sort of struggled with is, as you said at the very beginning, a very large percentage of people experience, a tear of some kind, most commonly, 1st or 2nd. But, I didn't know that before I gave birth. And I wish that I wish this had just been talked about more, like it was a little more informed about the risk factors and things like that. So yeah, what's your sort of personal opinion on that?
Yeah, so the number one thing I was going to say is I wish everyone knew how common tearing was, right? Like the first question I get from most of my patients after they deliver was, did I tear? And I'll be like, well, yes, and they're like, well, I really didn't want to tear. And it's, and I wish that we would have had that conversation. And, in my patients, I try to much earlier on in pregnancy. And, and that was part of the prenatal care to be like, this is a normal part of childbirth. This is what's to be expected. And, talking them through the normal things like a first and second degree, but also preparing them for the possibility of a third and fourth degree. I think a lot of times we don't want to, I think pregnant women often get babied sometimes, right? And you know what I mean? People don't want to have them worry about a third or fourth degree tear because it's like, oh, it's just one more thing for them to worry about. It's probably not going to happen to them, right? But I think a lot of patients are very worried about tearing. And I think addressing that head on before they have the baby and answering those questions will actually make people a lot less worried, knowing how uncommon a third or fourth degree is, and B, just knowing how common a first and second degree is and how it's probably not going to lead to much long-term sequelae. Yeah. And then the biggest thing I'd love to change in the healthcare community is just the postpartum care of this, right? And so really making sure that all patients can get into physical therapy, not waiting till the 6-week visits to follow up with these patients, making sure that everyone's pain is well controlled. I think people do a fine job during delivery about repairing these, and that's all done okay. But I think a lot of this is lost in that postpartum period. And that's what I really would like the medical community to focus on.
Yeah. And I think with, in just kind of work culture too, right? Like I, went back to work 3 months after having my daughter, and, I definitely was not healed. It actually took me a very, very long time to heal, but I didn't feel, again, because it's sort of there's a lot of shame around talking about things like this, especially like at that time. And I feel like had I had a more supportive work environment, I may have been able to continue to do the pelvic floor therapy for longer.
Yes, for sure.
Change.
Yeah. Right. It's not like, people kind of like, oh, you're back in 3 months. Okay, everything is great. Like, you're back to, and it's like, no. Like with everything that's going on, your body isn't healed. Many times you're still breastfeeding. Even if you're not breastfeeding, you still have an infant, and trying to figure out all those things. The expectation that you go back 100% and like nothing's changed is really unsustainable.
Yeah. Well, thank you. Thanks for sharing your knowledge about all of this. And I hope that, anyone watching or listening just finds it helpful. And yeah, thank you so much.
Thank you for having me. Have a great rest of your day.